happy holidays in whatever way you're celebrating them, in the dark days of the Northern Hemisphere or the bright days of the Southern Hemisphere. Um, we have both halves of the globe represented here today. It's a great pleasure to introduce our speaker, who's Dr. Tanya Solano. She works near to Toronto, Canada, in McMaster University system, and she's associate professor up at through the McMaster University program, and is actually very widely known in the world for her talks and her leadership in point of care ultrasound for children in the emergency medicine setting. Originally, she's actually stems from Costa Rica, where she did her original medical training and then has done residency and fellowship in Canada. And our moderator today, very pleased to introduce Laura Hurtado from south of Buenos Aires in Argentina, who is a long-standing faculty member at the University of Argentina, where she has been an instructor at the medical school, as well as a leading instructor of point of care ultrasound for residents and medical trainees for many years, and has also been on numerous committees developing point of care ultrasound around the world, and has been an important supporter and leader at WinFocus throughout its existence since the beginning. So I'll hand it over to you now, Tanya. Thank you so much for being here to give us this presentation.
Mm-hmm. Well, good morning, everybody. My pleasure, my honor to be here, trying to expanding our knowledge of point of care ultrasound around the world. We are going to just start saying thank you to the WinFocus team, Divine and Kent and Anthony, Laura, to just get together for this webinar and welcome you wherever you are in the world. I'm sad that I cannot see you, as wouldn't be in a very nice conference, which I can go eye to eye and have our interaction a little bit more alive. But I'm happy that I have a moderator that you can use, please use, and I will like to for sure try to address all your questions and make this webinar as participative as we can, because this is the issue, that now that we cannot be together, then we can actually use this kind of tools to try to get together. And just to start with this, I want you just to get out of here, just telling you that we want to go to get your mind. So I know that we're very busy. We have our phones, we have our kid, we have everything, but you're here to learn for a bit. So I want you to just get you distracted for the next 47 minutes and get your mind all here. We're going to be very exciting. We're going to get you to a place where I normally live more than in my house, where I currently here in Canada. And this is my hospital at McMaster Children's Hospital. So in my hospital, we're going to be looking for any kind of child with any kind of complaints. And we're going to be pushing our ultrasound machine to try to address their complaints. I have to just to disclose that I am point of care ultrasound lover. And as you can see, I will be trying to just use as much as possible for any child that we're seeing this ultrasound machine. From the point of care ultrasound, actually, we are going to be covered today a little bit more specific for loan and resuscitation, but there is a wide world of different applications that we can go through, from your skull, for your long bone fracture, papilledema, IV access. So I hope so in a series of webinars that we're going to be developing through this year, you'll be able to accomplish many of these other standard of care or point of care ultrasound applications that we're trying to learn day to day. This is a very old slide. I don't know if you have seen it or you have seen me talking anywhere else in the world, but I love this slide because I think that from the point of care ultrasound point of view, there are 4 things that should be standard and should be kept in your mind for the rest of what any application you learned. Well, we need to learn how to acquire the picture. So you need to learn what kind of probe we're using, where are we moving the probe, whether it's up, it's down, it's fanning, it's rocking, what are we doing? Once you acquire this picture, in the same way that when you ask somebody to get you an EKG, you need to be able to read it, which means you need to be able to interpret that ultrasound image that is in your screen. And one of the most important things that I try to pass to my residents, fellows, and colleagues is that we need to understand the limitations. We are clinicians. I am a pediatric emergency doctor. I'm not a radiologist. I am a physician. So my point of care ultrasound has limitations. And there are things that I can assume, there are things that I can see, and there are other things that I cannot call. And I will need to get my radiology, I will need to get other type of tests. And this is what is understanding the limitations. And once you have it done, then you have to integrate. What is the clinical picture? What is my child presenting with? And these 4 mandatory steps is what make a good point of care ultrasound person to use and interpret their picture. How we do that? We learn, we practice, we improve. And from the clinical picture, it comes to a piece of the puzzle. So there's a piece of the puzzle. What is my child having? What is the other? What is the vital signs? What is the heart rate? What is the appearance of my child? What is the complaint? What is the past medical history? As working in a pediatric emergency department, I cannot be using my machine for 15, 20 minutes. Everything that I use, I will try to limit those applications to 3 to 5 minutes to make my workflow a standard of care as my other colleagues that I use or not point of care ultrasound. And then starting with this small little introduction, we're gonna get to our PoCUS loan. So PoCUS loan is quite a well-known application around the world. There are hundreds of articles if you go to PubMed about showing you the evidence. And today we're going to be covering a little bit more pediatric specific evidence. The objectives, we're going to be able to acquire and interpret some image for the lung, demonstrating some pneumothorax, pleural effusion, pneumonia, pulmonary edema, and recognize some abnormal lungs that will require further study. These are things that have been talked before in our webinar, so we're going to make that very pediatric specific and very specific to my patients. And I will like for now and ahead that I have this few minutes by myself for you to interact and tell me what do you think about those cases. So we're going to start with our first case. So these cases are real cases, all of them. And then the pictures that you can see from them are not my patient, are what I can remember they look like and the best that I can search in the internet for their appearance. So this is Charisse. So Charisse is a very healthy 5-year-old who loves dance and swim. She has been feeling a little bit unwell for the last couple of days, and during the evening, mom described that she did have a little bit of decreased energy, and so she noticed that she was having some increased work bread later on during the day, and this is the reason why she presented to our emergency department. So when she arrived, we as a pediatric emergency physician always go to our airway, breathing, circulation, disability, exposure, and for us, PoCUS point of care ultrasound. Then we got the vital signs. So her vital signs, temperature was 39.8, heart rate is 136, and saturation was 86, and our respiratory rate was 48. So if you think everything pediatrics is age-based, so this is all of them are a little bit out. And having a little bit more of her history, we learned when she arrived that she is a child who has sickle cell disease and is complaining right now of shortness of breath and chest pain. So I would like to hear from anybody from the audience and Laura to help me with this. What kind of things you're suspecting? I have a little bit of clue there in my slide, but I would like to hear if you want to be worried about with these vital signs with anything specific for this patient. Laura, so tell me, you get any participant that are willing to type and just say what would they will be worried looking at this picture of this 5 years old with sickle cell disease, fever, shortness of breath, and chest pain? Or what do you think, Laura?
Here's Laura umbrella that says acute chest.
Yeah, so acute chest syndrome, correct. So this acute chest syndrome is something that is quite knowledge that we need to be aware of any child with sickle cell disease. We don't understand completely the physiology of this, but if you review the literature and you read a little bit about point of care ultrasound or anybody with sickle cell disease, you need to get changes in the x-ray. And the most important thing to make the diagnosis is because you need to be very careful about the amount of fluid that you're going to get in that child once you think about an acute chest syndrome. So in the normal world, people will obtain a chest x-ray for this patient. A chest x-ray is actually something very luxurious. We know by the World Health Organization that only one quarter of the population in the world will have access to chest x-ray. There are tons, millions of people around the world that cannot get a chest x-ray. Or maybe you work in an area that you don't have quick access to chest x-ray. And this is when the point-of-care ultrasound become your very reliable, usable, reproducible, no radiation example of you can use for a patient. What kind of probe that we use for these applications? In our pediatric population, and my pediatric population go up to 18 years old, and some areas in New York, they go up to 21 years old. The linear probe will be the probe that we use. I know that in adults, you use a little bit more your phase array or your cardiac probe, and they are totally fine if this is the one that you have. But our pediatric patient thorax is much smaller. They are thinner. There are not much tissue. Usually there are no breasts. They are not overweight. So there's a lot of things that are make much easier, clear, and nicer the picture for the point-of-care ultrasound and the lung. And this is why our probe choice is going to be our linear probe. But as I said before, if the only thing that you have is a transducer that is curvilinear or a phase array as well, these are the transducers that are classically used in your adult population. And thinking about what kind of picture you're using. So what are we going to do is we're going to just look for artifacts, things that are not there, because remember that an ultrasound is not very good friend with the air, and the healthy lung is full of air. And then what you have is just this nice picture that you're seeing now on my screen, where we're looking for the rib shadows in between. We look for the pleural line, and then in between, below the pleural line, you're going to have this reflection of lines. And these reflection of lines look almost like a mirror that you can see down for your soft tissue that is on top. And those lines that are underneath, we call it A lines, what are healthy lines. Probably a little basic for some of you that I know have some point-of-care ultrasound, but some of you that are just starting, I would like to just remember this type of picture that I want you to keep in your mind, because what is happening in Cherry's chest is very different than what you're seeing right now. From what kind of, or how do we scan the children? The way that we scan those kids is a longitudinal scan, where we include the anterior part of the chest, the mid-clavicular, and the posterior aspect, and the left and the right. If you have an area which you are interested in or you found an abnormality, then you can go in transverse. But our protocols and many of our pediatric children hospital as a scanning tool to look for the lungs will be this sagittal way that we just go from the anterior, mid-clavicular, and posterior for the kids to get scanned. And this is a protocol that has been described from many of our point-of-care ultrasound users from New York, and very well validated that we use. Now, coming back to Cherries, this is what we look at. So this is the first picture that we obtained for her. So I would like to see if anybody in the audience will be willing to tell us if this look normal or abnormal. And if it is abnormal, maybe we can just jump and tell me, what do you think is abnormal? And I definitely more than happy to point it out just to think. So Laura, do we have anybody that is willing to tell us if it looks normal or abnormal?
I think they are here one. Abnormal Zambi lines, says Gerardo Jesus Montes Amaya.
Okay, thank you, Gerardo. So absolutely. So as you can see,
sorry, Tanya, is another one.
Sure.
From Idris Arnaudet says B lines, fragmentation, pleural line. And
correct.
Another one, Pablo. No, it's another comment. Those about diagnosis.
Sure, 100%. So what you can see here is the pattern that I just recently showed you, which was the beautiful A lines that were down here, are completely gone. So we don't see that. What we see here is multiple B lines. Some of them look more confluent, some others are more separately. And the pleura that should be this very bright normal line that is here at the top is actually disrupted, and we call it thread disruption. So you see this small interruption, like look like somebody has bite that pleura. And this is because there are some subpleural consolidation happening up here. And as well as you observe this small area in the top, there is a small anechoic or no color black area that has some sinusoidal movement. And those sinusoidal movements are typical for a small pleural effusion. But this is just the beginning of what I'm going to show you for this little girl. So when we kept scanning, this is the picture that I obtained, and this is the posterior aspect of the right side of her thorax. So just to guide you a little bit about the anatomy here. So we have your soft tissue top, then you have your rib shadow, and then this is the pleural line here. And then here, your diaphragm, which is this double line that you're seeing over here. And we have the liver underneath. And what a minute. It doesn't look that I have a liver under and liver above the diaphragm. Well, that is because what you're looking at here right now is the hepatization phase of a pneumonia, where the tissue that we have in the lung, which was completely full of air and just a representation, a mirror artifact, is completely changed now. And you have here now air bronchogram. So these small, very bright speckles that you get in within this hepatization completely area of the lung are small particles of air that just got trapped within this space. Hepatization or consolidation of the lung is one of the most important findings for somebody you're suspecting in a sickle cell chest crisis or sickle cell chest syndrome. And in this case, we got a patient who present with increased work of breathing, shortness of breath, and chest pain. And this is classic. Kids with sickle cell disease by the age of 18 already have around 27 chest x-ray in average. So this is tons of radiation. So then in a group of people in New York actually thought, what about we do something different? And we tried to make the diagnosis of sickle cell crisis here and sickle cell acute chest syndrome in a child doing point-of-care ultrasound. What wouldn't be the accuracy for point-of-care ultrasound for those kids? And they found in their study where what they did is they were recruiting patients from any febrile episodes for 2 years, and every child that they see in the emergency department were getting a chest x-ray and they were getting a point-of-care ultrasound, and they compare the findings on both. And they found a sensitivity of 87% and a specificity of 94%. These numbers are fantastic. And they are numbers that you definitely can use when you learn point-of-care ultrasound to help to spare a chest x-ray in your child with sickle cell disease and fever. You can definitely make the diagnosis, start your treatment, and be more accurate about what are you dealing with. From the point-of-care ultrasound perspective, there are some findings that can help you out to make the diagnosis of pneumonia more specific. And one of them is the presence of dynamic air bronchograms. And I want to know from the audience, how many of you have been able to see dynamic air bronchograms? I would love to hear, because I have read it, I have seen it, one, after almost 10 years of being scanning little chests. And this is something that is quite described. You have a consolidation, and then you have your hepatization, you have your air bronchograms, but you're still concerning it is a mass. This is something that you can need to be confused. That can be a different type of pathology in the thorax. Having this dynamic air bronchogram make it very, very specific. They are rare. They are rare to see it. So you have to use other type of findings like your B lines, like the eruption of the pleura, the transition between the two of them, and of course, your clinical presentation. And having a lot of our pediatric patients with not much comorbidities, it make it more clear and make it more clean for us to make the diagnosis of bronchograms present with no dynamic or dynamic, thinking about pneumonia. So Laura, do we have anybody that had seen dynamic air bronchograms?
No one tell us. In my experience, I only see once dynamic,
Yeah.
and I have the video. It's old, and it's a comment from Larry Melniker from New York. He asks for confidence intervals and visualizations of rails. He's asking about that.
Can you repeat the question, please? He's asking
sorry.
about it.
Yes. I think that it's about the paper.
Sure.
And confidence intervals and visualizations of rails, maybe below resolution in pediatric patients.
Yeah, so when the study that they did, they found the positive likelihood radio of 14.6 with a comfortable intervals of 6.5 to 32.2, and a negative likelihood radio of 0.14 with confidence intervals of 0.04 to 0.52. Actually quite good, and an inter-observer agreement reviewed by an expert radiology of a kappa of 0.77. So I'm more than happy at the end of my presentation. I will get my email, my everything. I'm happy to share any of the articles, any of the information that I put it on, because I feel that the information is to share, and this is a way that we learn one to each other. Actually, there are some articles from the adult population where they show that some of the ultrasonographic findings that you can see with point-of-care ultrasound are definitely ahead of the radiographic changes. Same thing from pneumonia, where pediatric patient, I can see things much earlier in point-of-care ultrasound than the things that I will see in my initial X-ray. So that what is as well a very big advantage from our point-of-care ultrasound. And I hope that that responds the question that I have.
Tanya, I actually also have a question for you here. One of the key things that we teach people who are doing adult ultrasonography in their lung evaluation is to be sure to do an assessment for A-lines, and that requires that you actually have quite a lot of depth in order to see several layers of A-lines underneath the pleura. I noticed that when you're doing your scans here, you have very, very superficial amount of depth because you want to have high resolution of the pleural changes. But do you start with your pediatric ultrasounds by having more depth, and then do you sort of, when you've assessed for A-lines, do you then zoom in, or do you think you can confidently pick up your A-lines just with when you start superficially?
100%. So it's a great question, Anton. So think about it, a pediatric chest, correct? So if you think the diameter in a neonate is around 6-7 centimeters, so your 16 centimeters that you use in your adult population is actually not applicable because the chests are much smaller. And then the way that we scan, because we scan the anterior chest and then we go to the posterior chest, you kind of overload the two picture themselves. So we normally start around 8 to 10 centimeters deep, and then you can decrease or increase the depth based on what you see. And thinking about what are the limitations of point-of-care ultrasound, so mid like chest pneumonias can be missed, and we know that. But knowing from the literature, 99% of the pneumonias that are clinical significant will reach the pleura. So it's rare the cases that we will be able to miss, and especially if you follow very well your pattern of keep scanning from the clavicle all the way down to your diaphragms and from the anterior, mid-clavicular, and posterior, that gets you more reassurance that you are covering very well. If you are a little bit more worried, of course, you can just go in transverse in every single space, and that will help you as well with your depth. But I will say, yes, we go more superficial than your adult counterpart because our patients are much smaller, and then the resolution and the depth it no need to be, but 8 to 10 centimeter are what we normally do a start. And if you don't see anything, we normally go slightly up in our clips.
Okay, so another follow-up question to that. You say transverse, but there's always some confusion about whether you're talking about transverse with respect to the ribs or transverse with respect to the patient. When you say transverse, are you actually saying with the probe running in this direction up and down the chest, a transverse with respect to the ribs?
Longitudinal you go from the top of your clavicle all the way down, and then if you have an area you're interested in, you put your probe and transfer it, you scan in between the ribs, following the ribs spaces up and down.
Thank you.
You're welcome.
Tanya, there's concern from Arif Hussain. Arif Hussain is WinFocus president, and
Yes.
he'd like to know if do we have undiagnosed any sickling in the vessels and the role of color Doppler in pets, because he have seen it.
Yeah, so that's very interesting because I have seen some of the actually modules more than anything else from the use of color Doppler and or color within the hepatization. And I know that is something that has been taught as one more tool for use it. It's something that currently we do not use. I think that is something that we can explore, but in our point-of-care ultrasound world, we do use more reliant of our A lines, B lines, present of air bronchograms, rather than use color as a part of our assessment.
Okay, thank you.
You're really welcome.
Also mine here, because, and also Tanya, you will agree with me that children are always moving, and
They are
really complicated because it's movement.
And as small they are, you will see them playing with the probe, touching you, hugging your cables. They normally do not cooperate that well that your adults will, but actually I feel the quickness and the smaller they are, it make it more like easy to assess in terms of time. And if you have the help for the parents to get them distracted, of you are like, you get just something, a toy or something in the face, especially when they are like small children, it's quite easy. As well, another tip, using warm gel make a huge difference for them not to cry and not to be angry with you. And as well, sometimes even just let it touch the probe before you start scanning, make them comfortable that this is something that is not going to hurt, that is not going to make them uncomfortable, is a very good couple of tips for you to just make your point-of-care ultrasound more successful. Yes.
We need to be very creative.
Yes.
Sometimes. Would you like to hear your heart? Oh yes.
Yes. Yeah. I offer any kind of figures will be imaginary in your chest, and I can make it happen if they want to while we scanned.
Yes.
So coming back to our, I don't know, we have any other questions that we need to address right now, Laura, or I can keep going? Okay.
Now
so
keep going.
Coming back to our beautiful Cherry, so we made the diagnosis for her of acute chest crisis syndrome, and then we were very cautious with her fluid, and then we start her on antibiotics within the first 7 minutes that we were looking at this girl, knowing what's going on. We spare a chest x-ray for her. We didn't have to do the chest x-ray. We have a clear diagnosis. We have a clear path. And then fortunately, she did improve within 48 hours. Culture were negative, and she was able to be sent home within 3 days after her admission in the hospital. Now I want to move you to somebody different. Actually, this is Brian. So Brian was a very, very cute 4-year-old that I saw this winter. So because in Canada, we're winter half of the year. So it was at the beginning of this year that was winter, and now again in winter. So this child present to our emergency department, just knowing that he was very active, super active, non-stop running 4-year-old, which kind of stopped running. And that was the reason why Mama was concerned about him. And actually, she brought him to the emergency department. And when I saw him during my shift, he was coming after a reconsult. This is around 18 hours after he was seen first. And a very smart mama to just follow the instruction that we give it to her, which was, if your child gets sicker, if your child has more increased work of breathing, come back to us. Having him with the diagnosis of asthma when they left the emergency department, of reacting airway disease, viral induced, there are multiple talks, that there's a different talk, but he was home with puffers and oral dose of dexamethasone. When he arrived to my emergency department, and now you are in my company taking care of him, this is the vital signs that we got for him. So his temperature was 37.9, his blood pressure was 90/60, his heart rate 150, and his saturation 92%. So thinking about pediatric population, everything is age-based. So saturation, definitely abnormal. His respiratory rate above what expected. His blood pressure is still okay, definitely tachycardic. And a tachycardia that doesn't match what I see with the increase in the temperature. So this will be your first red flag for him, thinking about what is happening for him and why we have to be concerned. So reconsult 18 hours, we want to see what is happening. So as getting him reading in the chart what was the main complaint, I got the chart, we got the machine, went to the room, checked the history, and then this is what we got as a scanning him. So we are scanning the left side of the chest, and we're going to start with that part. So do you see here the soft tissue on the top? You see here your normal rib shadows. You see here your nice, very clean pleura, which has very good sliding, and you get some A lines coming down over here. A little bit of focus of that. You can get here these lines. And then as looking at his chest in that side, we were going to have a look in the right side of the chest. And the right side of the chest picture is very, very different. In that side, you see the disruption of the pleura that has been described for some of our audience. And you see this, again, hepatization phase in the thorax with some air bronchograms present, with multiple B lines underneath. Coming back up the right lower lobe, you see more of those B lines and as well this hepatization. So within a minute, or maybe minute and a half, I was already knowing that this is not just asthma, correct? This is somebody who has a pneumonia. And a pneumonia that I can clearly see, make the diagnosis, and even the parents can see it. And they were able to tell me, it does something different there. I say, yes, you're right. This is something totally different, what we're looking at here. Then keep scanning on him, going to the back in the mid-posterior line. This is the picture that I obtained for him. And I would love to hear anybody that I can tell me what they think is going on in this ultrasound of his chest. So Laura, do you think that there is anybody that will be willing to read for us what is happening here?
Okay, I think they are thinking about, but in the middle,
Yes.
I have a comment from Larry Melniker that he says, if their chest hurts, do you start at the point of maximum pain, or you only do the same? Because
I will do everything. I will, because I'm substituting or trying to substitute my chest X-ray for the point of care ultrasound. So I will scan the whole chest, but 100%, that will be a point where I will be more worried, and I will move my probe from longitudinal to between the ribs to just scan that area very specific to see if I can find something abnormal there. Now, from these scanned,
so Idris Aldernet says pleuropneumonia. I think that's okay.
Correct. And this is exactly what I'm looking at. So just going through the anatomy very quickly. Again, you have your rib shadows here, rib shadows, and then you have your diaphragm coming down here. You have a little bit of the kidney. You have a little bit of your liver showing up here. And then what you look at here is this space between the parietal and the visceral pleura. And this is a paraneumotic effusion, but it's not a just common one. It's a paraneumotic effusion with multiple septation in the brights within the pleural space. And this is something that we call a honeycomb pattern. You see that look like almost like there is a like bees in the middle of those holes. And this is something that rarely, not rarely, actually, I have seen a few cases in my emergency department, but this is something that completely changed your management. So in this child, now that I'm looking at this ultrasound, I know that this child is not going home. I know that Brian will need to be admitted. I know that Brian is going to need a chest tube. I know that Brian will need antibiotics. And I know that Brian maybe will have a complex state in our emergency department for his admission. So within 5 minutes, I have my diagnosis, my PAT, and who I'm going to talk to next for this patient. And if you look at the x-ray, I mean, at the x-ray, this is his x-ray. Yes, you can see there are some low consolidation. Yes, you probably will suspect that there is a pneumonia, but you don't suspect that what kind of very bad pneumonia is happening in this child and what kind of interventions you will need to do for him. In his specific case, we are applying the point of care ultrasound to make his diagnosis and make the diagnosis of pneumonic effusion, if like looking like NPM. And we are very, very trustful because we know the evidence about point of care ultrasound. So this is one of the best articles that I want to keep in your mind for the use of point of care ultrasound. So this is a meta-analysis that was published in 2015 for the use of point of care ultrasound in children, where they did a very vast review of the literature. So they review around 15,000 articles. And from them, they only select around 1%, where there were around 8 articles that met the criteria to be included in this meta-analysis, accumulating 765 pediatric patients from neonatal admissions and our emergency department. And from this review, they got a sensitivity of 96% and a specificity of 93% for patients with pneumonia in the pediatric population. I don't know what is your specificity or how much you love or you trust your chest x-ray, but this is absolutely comparable to our CT scans, which of course we do not have that study done because it's something that we cannot like radiate our children, but this is absolutely phenomenal. And this is why I feel so strong on the trust that I can put in my point of care ultrasound for the diagnosis of pneumonia in children. In Brian specifically, when we got him admitted and mama understand that it was something different than asthma, we got him in the hospital. He spent a month in our hospital, which is kind of a very long time for his pneumonia. He was in a very long course of antibiotics, having no improvement. He required one chest tube that didn't drain the things because you see all the holes that were happening in his chest. Then he got another chest tube where it wasn't even improving him. He did that. He needed to get intubated and spent a few days in the PICU. He was extubated. And until they did the video assisted thoracal decortication, he improved. They have to clean the cavity, they take away all this thing, they got the culture from there, and extremely, what I would say, the only thing that was positive for him was influenza A. Nothing else. They didn't grow any other bacteria. He fortunately recovered like 3 days after this VAS procedure. He got much better and he was able to, the fever subside and he was able to discharge home. But look at the difference that you can do within minutes of your intervention and your diagnosis and what you are doing. So this is a case that I feel really happy I was involved with, in the sense of how much improvement and how much different we made for him just within minutes, just using our point of care ultrasound. And talking a little bit about the evidence, actually there are a few studies that have shown that point of care ultrasound for a complex pneumonic effusion can be as comparable of chest CT. And knowing that a chest CT is a huge amount of radiation for our small thorax in children is something that you don't want it to use, and you probably will reserve those just for cases. In this case, a specific, Brian, they did a chest CT scan because he was not improving. And it was very interesting when I followed the case that they comment the chest CT is comparable to the ultrasound and there are no more information that we can add. So I feel very proud of what we found for him with his scan of his chest.
It's really
Any
good.
Any questions about that case? Any comment that we have? Yes.
One comment. It's really, ultrasound makes the difference.
It did. Really. It definitely made a big difference.
You save the child from get puncture for the pleural effusion, because you could see that there was not going to get out any fluid because
Correct.
of the, and also you avoid a lot of radiation, because a month with a child in care and in another hospital, it's one X-ray per day here in Argentina. It's
Wow.
one chest X-ray a day. It's
Wow. It's a lot.
terrible. And it's, yes, a lot. And it's a question of, with Larry Melniker, what are the sonographic criteria for chest tube?
So in this specific case, the main reason was that we know in our institution, I can just talk about my institution, we mainly do pigtails being ultrasound guided by interventional radiology, or they do it under the surgery team. But in this child, because there was this multiple loculation, we know that likely this small pigtail will likely just end it in one of the holes. So it wasn't something that the team, the surgery team, feel very strong to. So actually that was the reason that they choose to do a chest tube for him.
Okay.
So really to follow up on your point here, that the decision for a chest tube or pigtail or not is clinical. You don't.
Correct.
You base it on the size. You don't really base it on the size, but you really base it on the clinical picture, as well as the findings of whether or not you have a complex effusion versus a simple effusion, whether you have loculations, whether you have this honeycomb pattern, things like that. Is that how you make the decision?
Correct.
Okay.
Yes.
Tanya, if there's totally anechoic fluid effusion,
yes,
they don't consider chest tube if the size is
they
more
do. So if the child is hemodynamically stable and
Okay.
the child is like, it's not like you don't have like a massive effusion, they will do a pigtail for that child. Yeah. So that will be less, it will be a less worrisome intervention, and usually ultrasound guided under our interventional radiology team.
Okay. Thank you.
Could you just repeat the etiology? I couldn't understand what was
so in this child, at the end, even though that we did blood cultures, we did culture of the effusion as well, the only thing that I was positive was an influenza A. Nothing else grew anywhere else in his body, which is quite interesting. Yeah, so get your flu shots.
Yeah.
So especially this year.
Yeah.
So then the next case that I have, like the next paper that I want to talk to you for a second, is this paper that I was published in 2016, which is a feasibility and safety substitution of lung ultrasonography, chest radiography for diagnosis of pneumonia in children. So this is a wonderful paper. So this is a paper that just talk about how we can't decide or take away our chest X-ray and our pediatric population doing point-of-care ultrasound. So this is a randomized study that it was done in a center in New York as well. So New York is a very strong place that they produce a lot of our very good evidence for point-of-care ultrasound. So in this specific paper, they tried to just compare the reduction of point-of-care chest X-ray compared to point-of-care ultrasound in the population. So there were kids between 0 to 21 years who to present to the pediatric emergency department, and they were randomized to the group with the sonographer. They were 15 sonographers divided then in the novice group and the advanced group. The difference between the two of them were the one that they have more than 25 ultrasound were considered more like experts, and the one that less than 25 ultrasound as experience from the chest were called novice, and all of them were trained in the same standard of protocol or for point-of-care ultrasound of the lung. With after 1 hour of teaching, they did half hour or hands-on in healthy adults and pediatric patients, and then they were ready to go. Every child who presented to the pediatric emergency department during the period of the study that they were suspected having pneumonia clinically, they were randomized to the ultrasound group or the chest X-ray ultrasound group. And once the chest ultrasound group, they did the ultrasound, the clinician who was doing it has the choice of, if they were not sure, they didn't want it, like they were having some diagnosis uncertainty, they couldn't do the chest X-ray they want to. And the radiology group was having a point of care ultrasound to the chest and a chest X-ray following by that. And they found a reduction of around 38% of chest X-ray in the ultrasound group. And what they said, and that it hopes so this is something new that I want to introduce, is a number needed to scan. So you need to scan 2.5 children to reduce one chest X-ray. So this is phenomenal. And actually, for the group that they did have a little bit more experience, they reduced the use of chest X-ray in 60%. And in children less than 2 years, because the chest is actually small and they are thinner and everything, the reduction was 47.5%. So another great study to tell you how good can be. They were in the follow-up, no missing pneumonia, no admissions, no changes. Like the two groups were quite similar. Then they found no other adverse effect in any of the two groups. So you have there the little reference that a great paper just to show you how good can be point of care ultrasound for the diagnosis of pneumonia in your kids. Now I have Kyra. So for Kyra, we didn't have so much time because I don't know you hear it, but I heard the bell that is calling up to recess. Anthony, did you hear the bell that we need to go to recess? And I hope so I will take some of you with me to recess because I think we're dealing with something a little bit more serious here. So Kyra came and my nurse was quite concerned about her appearance. And she was brought in immediately to recess. Looking at her vital signs, she is febrile. She is 8 years old. So having her being 8 years old with a blood pressure of 76/45, this is hypotension. He's definitely tachycardic, considered the age, 156, and she is hypoxic. So the only thing that we know, she is 8 years old. She is a healthy girl, had a viral illness around 10 days ago, and then she's been tired and having some increased work of breathing. And here I definitely will need somebody, can be anonymous, can be with the name, do it whatever you want it, to help me out because I need to run this code. I need somebody to help me with the airway. I need somebody to help me with the breathing. I need somebody to help me with the indication, circulation, IV. So I want indication. Can somebody tell me, having deal maybe with a similar case like this, what would be the next step? What do you want to do? So Laura, anybody that can jump to tell me what to do for this girl, what they want me to do? Like, I just have a minute to just ask about allergies, medication. There are none that we are aware. She's brought by EMS. Mom is coming in the car. Everybody's worried. Everybody's running. So anybody that can help me and see what else will be the next step for do? Or Anthony, what do you want me to do for her? While we get people just to think what else we want to just jump and do for this girl.
Well, I think she needs some oxygen. She needs some intravenous access.
Correct.
And she needs she needs some fluids. And then I think certainly while we're doing that, if someone has an ultrasound machine, they can look and see what a cardiac and intravascular volume is because she's hypotensive.
Correct.
And make sure she's anyway, those would be some first steps. And see if she responds to oxygenation and a mask rather than being intubated because she's obviously so sick. But
yeah, she's very, very sick.
Here's the same. Arif says oxygen and intravenous fluids.
How much fluid? How much you want to give it? Like 8 years old, we'll get her that she's 40 kilos. So how much fluid we want to give it? Like this is a little bit off of our talk, but I think it's quite important for that case. How much fluid we want to give it? Because then we're going to use our resuscitation skills for this girl, and we're going to integrate multiple image for her from the cardiac, from the lung, for her IBC to try to help us to figure out what's going on and what will be our next step.
Yes.
So do we gonna give it 20, 10, 50 mL per kilo? What is the usual first step that we give it for those kids?
Arif says check heart, and Larry
Ah,
30 milliliters killer. But I
okay.
just check heart.
Check the heart. Smart, smart. I like it. So be cautious, correct? Be cautious,
Yeah.
because then this is the classic picture for somebody with septic shock. If you think about it, that and this is in our pediatric population, septic shock, especially hypovolemic septic shock, hypoxia being the reason for them to get to that stage is very classic. But as you are very cautious, when we went to see her heart, this is the heart that I encountered. So this is a suffering heart. This is not a normal heart.
Yeah.
If you see here in our part external long axis, we have here the left ventricle, which is completely dilated. We have the left lip of the mitral valve, which is barely moving. It's not just going all the way up here, trying to moving. These walls are not contracting well at all. They are not coming down. There are very, very poor ejection fraction going on here. And I can see definitely a dilation of this heart. Moving to her parexternal short axis as well, at the level of the papillary muscle, you see this squeeze that should be like a very nice balloon is squeezing, the fish mouth. When I can tell my kids when I scan them, they look like a fish mouth that is opening, closing. It's not happening here, correct? You have a very small pleural pericardial effusion there. And then when we move to her view of the apical fourth chamber, you see this very bad dilated left ventricle as well, completely ballooning to opposing to the right. And looking at her IVC, this is what I get. I get a plethoric, very dilated inferior vena cava, which is no changes with the inspiration and expiration. So that will be a very, very hard red flag for you to tell about fluid and as well this suffering heart. So for Kyra, we shouldn't give her more than 5 to 10 mLs per kilo. But as Anthony mentioned, she's hypotension, correct? She's hypotensive. So we need something else. And what we need to do for her is actually quickly jump to inotropes. This is not a child that I'm going to do a long proof or like, of course, will be oxygen, will be double IV, will be support of her airway, we will do the circulation. But this is somebody you quickly have to think about it. Go to inotropes because this is what is going to save her life. Looking at her lungs, you have this V pattern, which is multiple V lines in her thorax, where are full of fluid because the backup and poor function that she's having with her acquired congestion heart failure. And putting this together, we have a heart that is abnormal. We have an inferior vena cava, which is full. We have a lungs that are completely abnormal, full of V lines. And we have an abdomen that I spare just a question of time, which is normal. So what are we doing here? So we are talking about our RUSH protocol. So there are multiple protocols that are being created mainly from adult patients that are adaptable for our pediatric population. And what we're looking at here is just different areas of the body try to help us to differentiate what type of shock we're having here. And in Kara's specific case, we have her in cardiogenic shock acquired because of her viral illness, and she has this ongoing myocarditis. And thinking about how good we as a pediatric emergency physician are going to be making this diagnosis is quite good, actually. This is an excellent article that was published in 2015 where they authors to actually review more than 300 papers to try to get together a very good summary of the literature, adult and pediatrics. And as well, something very, very cool is they went through all the p-values for the different scans we were doing. And from this paper, we know the pediatric emergency physician can have an accuracy up to 91% for the diagnosis of left ventricular function enlargement and pericardial effusion. So in our case, Kyra actually only received 10 mLs per kilo because quickly we were able to identify that her heart was very, very abnormal. We started her milrinone as an inotrope, the best choice for her. And actually we ended to transfer her to SICKETS, which is our closer tertiary, we are tertiary center, but we don't have ECMO. So we ended to transfer her because many of these cases will ended to require ECMO and even a cardiac transplant. She was an ECMO within 5 hours after we transfer her through Orange to SICKETS, and she's having a very long, slow recovery. She's not completely normal yet, and they don't know exactly what is going to happen. But see the difference within your quick intervention, decision making, IV fluids, transport, resuscitation effort, and get her in a much better place quicker than you expected. So I don't know, Laura, if there are any comments, any questions about this case that I would love to address if anybody has it.
Everybody, same thing, myocarditis, intubate, says Arif, and Pablo from Chile, WinFocus member, says, please check the heart. So okay, but it's so important. If you have the machine and you can use it by yourself, it's okay. But if you have to call another physician to do that, it's not so good. That's why.
And many centers are only one doctor coverage, correct? Like they are not, we are double coverage. And in general, unfortunately, when we have our resuscitation, we will have another physician coming up and see what they can help at. Mm. But this is something that I can tell you, it doesn't take more than 5 minutes. Okay. I would say maybe 3 minutes to get this done and really have a good, clear path of what is happening and what do you need to do for that child.
Yes, that's why you have to do it yourself, because here in Argentina, pediatricians don't perform heart ultrasound, so they have to call the cardiologist, and you don't have the time to do that.
Yeah, well, yeah, and plus, like, they are like, you need to take the decision, correct? Like, this is somebody that is suffering and is like attending to like in a life-threatening condition, which is quite helpful for sure. Yes. Okay. So if we don't have any other questions, I will try to go to my last case, which it's another. Now we're going to change a little bit to a little human. So this is Isabel. So Isabel is 5 weeks, a female who was actually admitted to a community hospital with the very, very uncommon, sarcastically, diagnosis of bronchiolitis that we see hundreds every winter. And they were thinking because of her evolution not improving, having more increased work of breathing, being still febrile, she did have a secondary pneumonia. So they decide to transfer her. So this is a child actually was seen with a colleague at SickKids, and they decide to transfer her to SickKids for like as changing her to a center with more capabilities in case that she did complicated. In her way to SickKids, she decompensated. She was sicker. She was febrile with more tachycardia. And even though that she was in oxygen, that was the saturation that they were registering for her. So having her in the emergency department stopped it because the compensation, even though that she was inward to inward transfer, the team decided to get a look of her and have a look of her lungs. And this is the first thing that we look and we found in her lungs. So I would like to hear from the audience. Maybe we have some people that had kids with bronchiolitis and they have a scan their chest. And tell me if this is the classic picture that would you expect for somebody with bronchiolitis. So we let's like to see if somebody can share a little bit of their experience and thinking that this is what are you expecting to see in somebody with bronchiolitis, and this is a pattern that will catch your eye and you will be worried about what is going on here. Are you worried, Anthony? What do you think that this chest is looking like if you wouldn't think about your experience with your adult population that you normally scan?
Well, I would think of any disease that diffusely affects the parenchyma of the lung with some small subpleural consolidations that are diffusely through it. You know, and in the modern era, you know, this could also be a COVID case. I know it's an infant and she's been sick, but I think I don't know specifically how bronchiolitis is distinguished by pediatric ultrasound specialists from other diffuse lung conditions or lung infections, but to me it looks like a very sick lung with a lot of fluid in the interstitial spaces and some in the air spaces.
Correct. So, and this is actually like what you expected and see some like subpleural changes, so intermittent. There is nothing specific that I can tell you is for bronchiolitis that I can just see a picture and say, oh yeah, bronchiolitis. But you will have to expect a little bit more like a viral pattern where you have a small subpleural changes, and then you have some spare B lines and different areas of the thorax. But this is our multiple non-stop bilateral B lines, which is more than you expected. And for me and for our team was more like, this is not what you expected to see somebody with bronchiolitis. And then we move forward to a scan a little bit more, and we look at her inferior vena cava. With inferior vena cava, actually, remember this is a 5-way call. So this is not the prettiest study picture because it's something difficult to obtain in a baby, which has been poked and is being having multiple intervention, but promise that this was not really moving much and was quite plethoric and horizontal. And of course, we'll look at the heart. And this is the heart. This is the subxiphoid view for this baby. So I would like to see, because this is actually a very abnormal, rare heart that we sometimes see. Remember that we are, as I mentioned at the beginning, we are pediatric, we are clinicians doing point-of-care ultrasound. So I don't compare myself at all to a cardiologist, but having the experience of looking at hundreds of heart, I will recognize that is something abnormal happening here. And I would like to give it 15 seconds to the audience, because I will like really appreciate if somebody can jump and tell me what they think is abnormal in this picture.
Pablo from Chile says core triatum.
Oh, Paulo, I know, Paulo. Thank you, Paulo. You're the best. Then I will get you another picture of what is slightly more. This is the apical fourth chamber for this baby. And what you see here, as Pablo mentioned, you see your right ventricle, you see your left ventricle, you see your right ventricle, which is actually quite dilated, and your right atrium, which is as well quite dilated. And then you have here your atrium, which you have 1, 2, 3 atriums. So in this membrane that you have here is an abnormal membrane for this baby who was born with this abnormal cardiac disease, what we call it core triatum, which is can be on the right, can be at the left. And this is an abnormality that can happen in these children and is 50% associated with others abnormal heart condition. In her case specific was partial anonymous venous return, and she was in cardiac failure. That's what it was happened to her. And having the fluid that they talked about, because she was not feeding well, so she was getting more fluid, she was getting antibiotics, she was getting oxygen. None of those interventions wouldn't help her, because what did she need? She needed a surgical repair. For this baby, she was critically ill, she was in congestive heart failure and in pulmonary edema. So she was transferred to the critical care intensive unit, and she had a septoplasty done through a catheter. And when she was more stable, she was corrected surgically, and she's now doing better. But the point of this case is, even though you are maybe don't know exactly what is this core triatum thing, but you recognize that this is an abnormal heart. And this is a picture that is absolutely different what you will normally see in your pediatric neonate hearts. And there are multiple guidelines for us, from the consensus for lung ultrasound, consensus of your heart ultrasound, for what we are capable to set and ruling it or ruling out. But here is the point of recognition that this is an abnormal heart that you will need to call somebody else. In this case, we were sick kids, and then we're able to get the cardiology critical care fellow within 15 minutes downstairs, and they took the patient to the unit, and then she did much better, and she's now in a much better stage of her life. Any other comments, any other question, Laura, for our audience over there that we...
No, not about this, not about this case. This,
so I have a quick comment, Tanya, while Laura's looking through the queries, and that is really one of the big challenges that people who do point-of-care ultrasound have, is that the people who specialize in ultrasound imaging always say that because we don't have so much training, we cannot recognize rare and unusual entities like this core triatriatum, sorry. And I think it's very important to recognize that we are limited in that way, and also to try to maintain a sense of when things just don't look normal, even though we don't know why they're abnormal.
Exactly.
So I don't know if you have any advice for people about some pitfalls that you frequently can overlook, even though you can't make a specific diagnosis, but things in pediatrics that really are not that common, but are like oftentimes signs or signals that something is going on, that you need to acknowledge that someone else needs to take a look at the picture in a more advanced way.
Correct. So one of the, just actually did start from the beginning. So one of the most important thing is keep always your orientation. So be sure that when you are doing your image, you keep your orientation always to the right or always to the left. Doesn't matter if you do it to the cardiology way or you do it to the pediatric emergency way, keep your orientation consistently. Because then when you are assessing the size of the chambers, you want to be able to always be able to recognize what is the right chamber, what is the left chamber, because that can be absolutely different from a pediatric patient where they can have in the first week of life a little bit more similar right and left sizes, and that change over time. But if it is completely, you are at this baby at 4 weeks, 5 weeks of life, and that right side is absolutely massive, then you have to think immediately, this is abnormal. Do you see an extra chamber there? And remember, you do the diagnosis of ventricular septal defect multiple times, just listen at a child, correct? And having the clinical suspicious. I don't want you to do the diagnosis with your ultrasound, but of course, if you are suspecting and you go and do your apical full chamber and the left side is massive dilated, then you have another clue to talk to your team. So for me, it's more than pattern recognition of what is normal. And when you find something abnormal, you will say, this is above or my scope. I will need to consult cardiology. I will need to do a referral to the much knowledgeable team that need to address this specific find. But keeping your orientation is one of the most important things. Try to scan healthy hearts just to get your memory of how to acquire your image as well, and have to that in your mind as well. And then IBCs, knowing of what is the normal IBC for any child like this. And of course, like if you are suspecting somebody with bronchiolitis, I mean, now COVID will make the things a little bit more complicated, but unfortunately COVID is quite rare in children and they usually don't get that sick. So you have somebody that look like cardiac heart failure in your pediatric patient, is probably cardiac heart failure and not something else. So that will be a few of my tips that I can actually pass to our audience.
Yes, thank you very much. Larry from New York and WinFocus, totally agree with you. First rule of PoCUS, know normal and what ain't. Second rule, no patterns.
Mm-hmm. Great. And then actually talking about PFALs that you just mentioned, and then we don't plan on this. I want to show you a couple of cases, my last case, because a matter of time for our audience. This is a case that is classic. 3-year-old Carlos, who came to the emergency department with fever 38.2, with a normal heart rate, with a little tachypnea. That cute. He was actually dressed in something like this. I loved it. I mean, working in a pediatric emergency department is the best. I have to tell you that I kind of biased. But saturation around 95%, which means it's slightly low, but he's not tachypnic. He's like not that bad. So we look at his chest, and this is what I got in the chest. First, mid clavicular, left clavicular side. So then what we're looking at here, is this a pneumonia from the little talk that I give it to you? Is this something else? I know there are some people in the audience that actually can't maybe recognize this, but I would like to hear if we have a volunteer that can type up what they think we're looking at right now. So little Carlos, 3-year-old with classic pneumonia, kind of suspected pneumonia. What?
Suspecting pneumonia.
Yeah. What?
You said this is you're just below the clavicle. Is that right?
Correct, just below the clavicle and the left side of the thorax.
Yeah, well, I mean, I again, I'm not a pediatric specialist, but I know that young children, the thymus can be up there, and this, if the kid's not very sick, and I mean, I wonder if this is the thymus. We used to learn to see that on chest X-ray, and I don't know if that's what we're seeing here.
You are absolutely correct. So this is the thymus. So the thymus is a solid organ that can be a big pitfall. And this is part of what I teach my students when I have them in my point of care ultrasound rotation and my fellows, because this is something that is easy to get you fooled because you have a solid organ, but now the clue for this would be you don't have changes within the space. You see that the transition here is very clean. So you have your normal pattern of sliding with no disruption of the pleura. You have your A pattern, and then this organ, it has a much better knife consistency. We call it a stereo knife. I don't know, you like think about a stereo, little stars, little dots here inside. Then you have no air or no fluid bronchograms happen within this space, and the classic location mid clavicular left side of the thorax and somebody which is a young child less than 5 or so. When we kept scanning Carlos, then we look up here, the thymus is still, but we're going down on the left side of his chest. We then see this abnormal pattern of B lines coming down, disruption in the pleura right here, and a little bit more of air bronchograms showing up down here, and going down to the level of his spleen and his diaphragm. Then you have this small subpleural consolidation here, very easy to see it with multiple confluent B lines going down. And this area, I wanted just to kind of get a little comment here, is a very tricky area for pediatric patients, because if you do not recognize the diaphragm is an easy pitfall, come down to the abdomen, come down to the bowel, and call that a pneumonia. And I show you this in the next picture. So this is somebody, that's a different patient, which we were scanning to the mid-clavicular left, mid-axillary left side. And then you have here a very small area of the diaphragm, and then here. So this is a full stomach. This is a beautiful baby who just fed. And then you see here the stomach with multiple fluid and some air there. That's what makes them having colic. But you can call this pneumonia. You are not very careful of what you're looking at when you pass your diaphragm. So a very tricky area that I want you to just get your attention there. That is something that you have to scan carefully, the left lower lobe. And this is a cool case, actually, that was published with one of my very good friends at SickKids, Greg Harvey, which what they got is this child with a very beautiful, well-defined thymus and a pneumonia right beside. So this pneumonia, you can then see the difference between thymus and the pneumonia with some fluid bronchograms and hepatization, and then down here with some confluent B lines, but the thymus been in a different consistency. And you have in your right side the comprehensive X-ray for what it looked like in the chest X-ray, that probably you maybe won't be able to make the difference which is which, but having your point of care ultrasound reproducing this beautiful picture. So any comment about this? Have people in the audience had seen the thymus? They maybe think that it's a pneumonia, is something a common finding that you have seen, Laura? Do we have any comments there?
So just to tie up the case, if you could, while Laura's looking for the comments, in this little boy that you were treating, you saw those small consolidations and abnormalities in his lower lung fields. Did you think that he had a bronchopneumonia, and therefore you treated with antibiotics in that case?
I did. So these consolidations that are more than 0.5 centimeter, they are no subpleural, they have hepatization, they have multiple B lines. And of course, remember, this is piece of the puzzle. As I said at the beginning of my presentation, he did have fever for more than 3 days. He had a little bit of hypoxia. He was well looking. So this child, I made the diagnosis of pneumonia. I got him on antibiotics. I did not X-ray him, and I sent him home with a good follow-up with the family physician within 48 hours.
I mean, I think the chest X-ray, there's a good chance that chest X-ray might have been negative.
Maybe.
And I think the ultrasound but that tiny little consolidation above the costophrenic angle, that would be very easy to miss on chest X-ray. So
completely correct. Yeah.
Yeah.
It's like.
Do we have any comment, Laura?
No, we don't have.
Okay, sure.
One
So,
other question for you, just sort of to tie up some of the things you've been talking about. I think the case that you talked to us about with the young girl who came in looking like septic shock, who actually had cardiogenic shock, is very instructive about the way we use ultrasound, really to differentiate shock. And even though, you know, in that case, probably 95% of the time you would have been okay just betting it was septic shock, that was the 5% of cases where, you know, treating for septic shock would have been very, very bad and dangerous for that child. And so, and really, and you used the Rush protocol. You showed us the Rush protocol, which most people are familiar with. In what ways do you feel that you have to modify the Rush protocol, or do you add to it, or subtract to it, or change it in your practice with children when you're just evaluating for undifferentiated shock? How is your practice different from adult sonologists when you're doing that with ultrasound?
sure. So thinking about what is the etiology in pediatric patients. So our pediatric population, one of the most common reason for that is lung related, correct? So cardiac arrest or anybody like hypoxia is one of the major issues. So for us, I almost always start with the lung, like meaning the child is tachycardic, but we are just doing the IV, we are not getting fluid yet. The first thing that I will scan will be the lungs, because I know that a lot of my answers are gonna be sitting there and I can see better what is going on within the lungs within seconds. Then I will move to the heart as my second step, just to see if I'm gonna give a fluid, if there is any unknown abnormalities. And as well, in my small pediatric population, I will use my point-of-care ultrasound to check for pulses. So I will check for the pulses in the femoral area and somebody that I'm suspecting cortilation of the aorta, or if somebody is having a cardiac arrest, and then I look if there's true or no pulse, which I think this is going to be part of our talk for our next webinar about the use of point-of-care ultrasound with our resuscitation and cardiac arrest. So looking at the pulses as well, because as we know, the check of the pulses is non-reliable in adult population, not either in our pediatric population, and it's quite hard to feel the pulse. So ultrasound can be a huge advantage of checking out the pulse, especially if you don't know about femoral pulses. And I have a case that I recently had that the child actually have an unexplained deterioration after a circumcision. And I was like, this child has to have an aortic cortilation. Now this, like, they should be something like that to just for the type of top process that I have. And I couldn't exactly feel perfectly the pulse, put my ultrasound, I did see the pulses, they were present, out, there wasn't, it was something different. So it's just like one more area of you can be helped with your point-of-care ultrasound. Now, for me, we don't check the aorta, we do not check our pipes, because fortunately, looking at the aortic dissection or any of those things are things that we don't see. DVT as well is rare, but I see up to 18. So if I have risk factors and my patient, like they are teenager, they are in contraceptive, they have any other thing, then I will look for DVT. But probably the part of the pipes is one of the most that I don't do very often, because we don't have to look at the aorta in our pediatric patients.
Okay.
Super.
Okay. Thank you.
Yeah. So then,
Yeah.
just to summarize, so remember, point-of-care ultrasound is better than chest X-ray. Incorporate that to your patient with distress hypoxia. Your number needed to scan is 2.5 children to decrease 1 chest X-ray. Scan the anterior chest in healthy children to familiarize yourself with the thymus. And early identification of paramnemonic effusion is critical, as will change your management for your patient. And for PoCUS, for anybody related with resuscitation, allow those findings to be directly correlated with your patient's signs and symptoms. We are doing something goal-directed, simplified, problem-based assessment, and it's a tool to enhance your patient care. It's something else that you add for your, that you have your team working, you have your multiple different ways to monitor a child. There are multiple tools. I know what is my favorite, as you can see, And I hope that you enjoy this webinar. If you have any other questions or anything that I can address, here my email from my institution, and this is my Twitter account that I'm happy to share anything that you wanted to learn. And I'm open to any other questions, comments, or anything else.
Thank you. Thank you, Tania. Amazing presentation. Love you. There's no more questions.
So
Well,
quiet.
Yeah, thank you so much,
yeah.
Tanya. Oh, is there another one? Go ahead.
Okay. Larry, Arif, excellent webinar. Larry Melniker. Daniel Lichtenstein studied CHF versus COPD. To age point, differentiation CHF versus sepsis may be more important.
Correct.
Yes.
Yeah, in our pediatric population, COPD is like no present. Like,
no present.
So correct. So then you are doing your pediatric patient. Yes, apply your adult knowledge, but put together that you're gonna have a much healthy, cleaned type of differential when you're having children. Yes.
Yes, I think that it's very important to incorporate insonation to our diagnosis cascade, because without clinic, ultrasound is not.
It not work by itself.
It's not
correct.
Yeah. I think that's the tip.
Well, we're coming up on the time here, so I think I'm going to just thank Tanya again for the superb presentation. Hopefully it's been useful for everybody. Certainly, I've learned a lot. Thank you, Laura, for your time as the moderator. It's been excellent. We are planning to draft and publish a webinar over this similar topic on pediatric sonography with the same team, with Tanya and Laura, in early February in Spanish. So if you are listening in in the Latin and Hispanic speaking countries, please put February the 11th on your calendar for people who are unable to attend this or who prefer to hear it in Spanish. Thank you very much to the team, Davide Neri and Quim at WinFocus for setting up this platform and making it work so well for us. Do you have any other comments, Davide?
Yeah, thank you very much, Anthony, for making this possible, and Tanya and Laura for making this webinar a successful one again. It was great to attend this webinar. And I invite everybody to become a WinFocus member so that you can access to this, the recording of this video. And feel free to write us at secretariat at winfocus.org. And we are going to answer all your questions and to give any kind of support that you may need to become a WinFocus member. Thank you again to Anthony, Tanya, and Laura for this great webinar.
Thank you. Thank you very much.
Thank you.
Thanks, Laura.
Holidays.
Thank you, and have a good day.
Thank you to the audience.
Have a good day and happy holidays.
Bye.
Thank you.
Happy
Bye-bye.
holidays.